Good evening, everyone, and thank you for registering for this evening's webinar on women's health with Dr. Mary McCaffrey. My name is John Windle, and I'm the General Manager of UPMC Sports Medicine and UPMC Institute for Health in Ireland. For those of you who may know or may not know, UPMC has 4 hospitals in Ireland: UPMC SSC in Dublin, UPMC Kildare, UPMC Oreven in Kilkenny, UPMC Whitfield in Waterford, and we also have 2 cancer centres, Hillman Cancer Centres in UPMC Whitfield in Waterford and the UPMC Hillman Cancer Centre in Cork. This evening we're delighted to have Dr. Mary McCaffrey, who's a consultant obstetrician and gynaecologist working from the UPMC board practice in Mallow, County Cork. Dr. McCaffrey's clinic offers a range of women's health services, from menopause care, gynaecology services, pelvic pain clinic, and mood and hormonal health. Dr. McCaffrey's talk tonight will focus on midlife to menopause, and for the sake of time, we will have any questions on teen in the Q&A. So if you have questions about teen health, midlife health, or menopause, please type any questions in the Ask a Question tab below, and we'll have a live Q&A after this talk. I'm delighted now to hand over to Dr. Mary McCaffrey.
Hello, my name's Dr. Mary McCaffrey. I am a consultant gynecologist and I'm part of the network of consultants and doctors who work with UPMC Ireland. And I lead up the team with our UPMC Women's Health Clinic in Cork. Today we're going to talk about health in the midlife and onwards. And an interesting fact is that if you look back into 2 decades ago, in 1850, the age of menopause was 46 and our life expectancy was 46. So women lived at a time when they almost died after their menopause. Nowadays, the average age of menopause is 51 years of age, and our life expectancy is somewhere between 82 and 85 years of age. So we spend approximately a third of our life in our postmenopausal years. And when you look at our next slide, I'm going to talk about the fact that it's important to make those years healthy years. And the foundations of our healthiness often starts in our early 20s, but it's never too late to start trying to get healthy and have a team of doctors and healthcare professionals who can help you with that. So now we're going to talk about the symptoms of menopause and perimenopause. And in this slide, we're looking at a long list of symptoms. But I think the first thing that is important to talk about is what the terminology menopause and perimenopause means. So the word menopause means that a woman has stopped her periods. And we use the phrase after a woman has had 12 months without any periods. But in the lead into the years of menopause, we now know that there are years called perimenopause, and this can go on for 8 to 10 years before a woman actually starts the menopause. And during those years, a woman may have subtle symptoms of menopause. She may have them intermittently during times of the month. They may come for a period of time and go for a long period of time. So they're quite variable and cyclical. And the sort of symptoms that we would see in the perimenopause, first of all, would be that periods would change. They can become heavier, they can become more irregular, they can become more spaced out. The biggest symptom that everyone knows about and thinks about is hot flushes and sweats. And we know that approximately 80% of women will get hot flushes and sweats during the perimenopause and as part of their menopause. Other women can get subtle joint pain, not just maybe a pain in a knee or a hip, but they can be generalized pains in small joints, in the neck, in different joints in the body. People talk about their energy levels varying and being quite low. This can be partly because maybe they're not sleeping so well, they're exhausted from the sweats at night. And obviously another symptom people talk about a lot is memory issues. And this can be a worrying symptom for women because they worry that maybe it's the early signs of dementia, but most of the time it's nothing like that. Women are tired. We're part of a sandwich generation, looking after our jobs, looking after older relatives, looking after children. So it can be a really tiring time for people. And one of the first things that people can find is that they can't remember simple tasks where they put something, someone's name, might take them a little while to figure it out. Mood issues are another symptom that are very commonly mentioned as part of the perimenopause and menopause. And we would see this as being a symptom that happens very much in perimenopausal women. They can become quite anxious, sometimes depressed. The women that are likely to suffer with these symptoms have often had maybe postnatal depression or anxiety in the past, a history of depression or anxiety in the past, or they may have what we call premenstrual mood changes. So mood can become very variable in the perimenopause. And part of the reason that it's more common in perimenopause than menopause is that our hormones can be incredibly erratic at this time of our lives. Palpitations can happen, and people often worry that this can be part of heart disease, when in fact it can actually be often part of anxiety and often a symptom of anxiety. When you talk to people, they can work that one out when you take them through their symptoms quite thoroughly. Insomnia and lack of sleep can be partly because of hot flushes and sweats. Anxiety, it can be maybe part of sleep apnea, and palpitations we've mentioned, and loss of sex drive and libido can also happen. And over time then our connective tissue, our muscles, our bones, and our collagen can reduce in quantity, and that means that we have less strong bones, less strong muscles, particularly in the pelvic floor. That can be important. And this can be very linked with vaginal thinning. So the most important thing I want to zone in on today is about health issues. So while symptoms are very important, it's important for people to realize that health issues can be going on silently in the background without realizing it. The most important health issue we consider now as doctors when we see women who are older is heart disease and stroke, because this is the most likely thing that's going to affect your life, affect your quality of life, and be the highest risk for mortality. Then osteoporosis due to bone thinning is another health issue we need to be mindful of. Brain issues are important, and we know that also sexual problems and problems with the vagina and bladder are also important. So menopause and cardiovascular disease, a very important topic. So we know that heart disease presents differently in women, and we're going to look at that in more detail in another slide. But we know as well nowadays from a lot of recent research that having earlier life risks, early life traumas, we talk about adverse child events, that having incidents like that lead to a higher risk of heart disease and stroke later on in life. We know that having pregnancy-induced hypertension and preeclampsia also increase your risk of heart disease later on in life. So these are important groups of women that we're very keen to zone in on and help them with their healthiness. And remember, I said earlier, it's never too early to start. So if someone has had high blood pressure in pregnancy or preeclampsia, then straight after their pregnancy going forward into the future, they can look at healthiness and what they can do to protect themselves. And we know that one of the benefits for women who have a tendency towards heart disease or risk factors for heart disease is to be on HRT and to have it prescribed early. And we know that from previous Danish studies that you can reduce your heart risk much significantly, even as much as 50% if it started within 10 years of starting menopause. Obviously, we like to start HRT for cardiovascular protection before age 60 if possible, but women do come to us after age 60 who need HRT for a variety of reasons, and we'll always try and start on the lowest possible dose, because in the past it was thought that if you started HRT after 60 that you increased the risk of cardiovascular disease, but we now know that that's not actually true. There's a really good infographic in the next slide, and it shows us a little bit about the warning signs of heart attacks in women and how they are actually quite different to men. So women will often get subtle symptoms. It might be more like epigastric pain, heartburn, exhaustion, different kinds of symptoms. And there's a really good American website called Go Red, And we've put this at the end of this presentation for people to go in and research in. I think it's the biggest resource I've come across recently that will help people. So I've mentioned all the different things about heart health that we need to know, and I think they're very important. So the next important area to focus in on is our bones. We reach our peak bone mass in our 20s and 30s. And for some people who may have had illnesses in their 20s and 30s, such as maybe an eating disorder, or they may be celiac, or they may have different reasons for not being exposed to adequate vitamin D and calcium, those women may actually have a lower peak bone mass than even their peers in their 20s. So knowing that our peak bone mass happens in our 20s and 30s, this is important that we look at how we're going to maintain our bones going forward into the future, because osteoporosis is a silent disease. It's a very serious disease. We know that women who, for example, have a fractured hip, 60% never go back to full independent living. It affects lots of aspects of their lives, including their confidence. And I see this all the time with patients who maybe have a fractured hip, and they become really anxious about falling, really anxious about their balance, and just generally anxious in their lives. So it's important for us to protect ourselves from getting to that point. And anyone who has a fracture from falling from their own height, that's usually not a good sign. It's different if you fall off a roof or fall off a horse, but getting a fracture from a small fall like that means that you really should be focusing in looking at your bones, possibly having a DEXA scan, possibly looking at something called a FRAX score, FRAX, which you can do online to score your risks for osteoporosis, which might include having a family history of osteoporosis, having your own history of rheumatoid arthritis, different risk factors, low vitamin D, so important to look at. So in terms of bone health, we would recommend that most people need vitamin D because most of us in Ireland don't get enough exposure to it. We recommend resistance training because that builds muscles, and muscles help to build our bones. We look at nutrition as well for women who come to us who might be at risk, and we encourage all people to be doing all of these things because they're important for the future. So nutrition, high protein diet, an adequate amount of protein, looking at your omega-3, 6 and 9 for your heart and your bones and your brain, looking at leafy vegetables for all the multivitamins. And then there are also medications that people can take if they have thinning bones. And as part of that, we know that if you're taking HRT, it does offer protection against osteoporosis as part of an overall medication package and lifestyle package. So then the other area that people worry about is brain function. And we know that HRT may reduce the risk of Alzheimer's and dementia. We wouldn't put someone on HRT just purely to prevent Alzheimer's or dementia, but we know that if people are on it, it can really help. But there are other risk factors for dementia as well that we know: social isolation, having hearing issues, having sight issues, being depressed. So all of those factors, when we meet someone in a consultation, we look at these things and encourage them to lead a healthy lifestyle for themselves. There's one small group of people that I would like to talk about, and we call it premature ovarian insufficiency, or POI for short. In the old days, it would have been referred to as premature menopause. They're a very small percentage of the population, probably only about 1% of women with menopause, but it can happen because people maybe had their ovaries removed early on in life. They might have had chemotherapy, radiotherapy, something that stopped their ovaries functioning. And we know that for those people, they're under 40 years of age, I need to say, that they're going to be exposed to lack of estrogen for longer. So all of the risk factors and health issues are likely to happen then for longer. And we know that HRT is very, very important for these people. And we know that HRT may reduce the risk of Parkinson's and dementia. The one area that people worry about when they think about menopause and think about hormones and HRT is breast cancer. And they worry about the risk of breast cancer because there was so much publicity about it at the beginning of the millennium. But we know now that the studies that produced that risk were actually quite flawed, and that they have been revisited, and that the risk of breast cancer is actually minute. Now, we would always, when we have people on HRT, review them after a number of years. We review everyone every year. I personally review all my patients every year. But at the 5-year mark, we would look at risks for breast cancer. We would make sure people are doing their breast examinations, having their mammograms. And the research is very clear that being on HRT really only increases the risks to 1 case per 1,000 people per year. So that risk is very small. It's much smaller than if you were a cigarette smoker, much smaller than alcohol intake, other lifestyle factors. But it's all about patient choice and about risking that. So while we would look at that in that scenario, we wouldn't usually prescribe HRT for people who've had breast cancer or who are at very high risk of breast cancer without talking to their oncologist. And there are so many other good alternatives nowadays. The one area that comes up quite a lot in consultations is that if someone's had breast cancer, one of the most worrying and annoying side effects for them can be the vaginal dryness and bladder discomfort that can go with vaginal dryness. And I think it's important for people to be aware that vaginal estrogen is actually safe for menopausal women who have breast cancer. And we always link in with their oncologist. We can use other things as well. But when you take vaginal estrogen, it's minimally absorbed into your body, so should be safe. So I've mentioned HRT, hormone replacement therapy, over and over. Well, will we talk now maybe about what is hormone replacement therapy? So when we talk about hormone replacement therapy, we're talking about replacing the estrogen that your body is no longer producing in adequate amounts. And that estrogen can be given by a tablet. It can be given through your skin, either through a patch, which you use twice a week, or as a gel or a spray, which is used every day. And that helps to replace the estrogen that your body is not producing naturally and physiologically anymore. But if you were to take estrogen in isolation on its own and you still have your womb present, then it can cause thickening of the lining of the womb, which is abnormal and which ultimately, for over a long number of years, could go on to become something sinister. So when we put people on estrogen for hormone replacement, we also give them something called a progestogen, which balances out those side effects of the estrogen and the impact on the lining of the womb. And that's usually given by an oral tablet, or we can also use the Mirena coil, which is a progestogen releasing coil that's placed in the womb. We can use that for progestogen also. And very occasionally, we give the progestogen as a vaginal medication. And depending on what your consultant or GP has decided, you'll be on a tailor-made regime for yourself. It's also important to be aware now that the government brought in free HRT for women from the beginning of this year. So any medications that you're getting in relation to menopause that are hormone replacement therapy are available to you with your drug payment scheme. So now that you know what HRT is, who and why do we prescribe HRT? So primarily we prescribe HRT for the control of menopause symptoms. And the symptom that it really controls most is the hot flushes and sweats. I've mentioned that it also can be part of your treatment for your bones, but we're primarily using it for hormonal control of hot flushes and sweats. And then when you're controlling your hot flushes and sweats, it may also then impact on your insomnia, which the hot flushes and sweats might have been causing. It'll help with your memory and all the other energy levels that go with that. And most particularly, can't mention often enough, women with premature menopause and the importance of them having access to their hormone replacement therapy. So when do we not prescribe HRT nowadays? And I would say nowadays it's actually very rare that we don't prescribe it. I've mentioned breast cancer. I think there'll come a time when we probably will be able for certain types of tumours to prescribe it, but at the moment we don't. Cancer of the lining of the womb and endometrial cancer, I have a question mark after that, because now in the States, they're starting for very low grade endometrial cancers to prescribe certain types of HRT. Women who have a high risk of blood clots, may be at an increased risk if they're on HRT. Usually if they're on oral HRT, that would be the problem. So we would use, where possible, the transdermal types, the patch, the gel, the spray, in the lowest possible dose to control symptoms. And I would always link in with someone's hematologist, their blood specialist who looked after them for their blood clotting disorder, because they'll often add in a blood thinner to protect against that. So it's all about looking at quality of life and what can we do to help people. And obviously, if patients aren't keen on being on HRT, then we respect that choice and we look at what other alternatives are available for them. And there are lots of alternatives to HRT. The most important thing, and we look at this with everybody in every consultation that I do, we look at lifestyle changes, because we know, for example, that having a higher BMI will give you a greater preponderance to hot flushes and sweats. So looking at maybe weight management, exercise, having a low GI diet, a Mediterranean diet, all of those things can help with hot flushes and sweats. Looking at your clothing, what you might wear to work every day. Can you layer your clothing so that you have different layers that you can take on and off? Having a cool environment where you work, where you live, and particularly in your bedroom. And obviously bed clothing, bamboo sheets, different kind of cooling aids, everything like that can be very helpful. Then there are lots of non-hormone replacement therapy options. The most useful one that's come on the market recently is a medication called a kisspeptin, and the one that's licensed in Ireland is called Veoza. And kisspeptins purely work for hot flushes and sweats. So they won't help, for example, with exhaustion or whatever, but if the exhaustion and other are factors related to hot flushes and sweats, then that will be very useful. And we do need to take a very careful history to make sure there aren't other things going on like depression, burnout, things that would be managed very differently. And other medications that are available instead of HRT is an old medication called oxybutylene. We used to use it years ago for an overactive bladder. We still do sometimes, but that can be very useful for hot flushes and sweats and good to give at nighttime. Medication called gabapentin can be used. And then medications called SSRIs and SNRIs, people might know them as antidepressants, but in very low doses, which we wouldn't be using for depression, they can be very, very useful for hot flushes and sweats. And they'd often be the kind of medications we would use for certain breast cancer patients who can't take estrogen. And then, of course, there are talk therapies. And the NICE guidelines from the UK talked about this last year, about the benefits of CBT, for example, for managing menopause symptoms. And people were a little bit up in arms about it. Not sure that they marketed the message very well, but it can be very useful in conjunction with HRT or for very particular symptoms such as insomnia. So they're all very useful alternatives that we can work with. And it's very rare that we would not be able to come up with a solution for someone with symptoms. So if someone comes to our clinic for a consultation, what would they be expecting to happen? The first thing we would always do is have a very detailed history. We go through menopause symptoms in a lot of detail. We look at family history in a lot of detail, because very often looking at the history of your family can be very important, particularly important for looking at cardiovascular and stroke risk, important for your osteoporosis risk. So we get a lot of information from that. And we do things like cardiac screening. We'd start off with the Q risk score and may follow that up with looking at certain blood tests, certain cardiac tests. And then we look at emotional health for every single one of our patients. We think this is actually really important. So we would screen for depression, for anxiety. And if there was any suggestion that maybe someone had burnout, that can be a useful screening tool as well. It's called the Sydney Questionnaire for Burnout. And then we give people information resources. We can suggest a treatment plan. Sometimes women come in very well informed and they've decided already what their treatment plan might be, and they might decide they want to start HRT that day. And if that's the appropriate line of action, then we'd be very happy to support that. It might be that we need them to look at lifestyle changes. And very often nowadays, we look at onward referrals to other consultants. And in the area of cardiology, that's really important, because we might want someone to have a more detailed cardiac screening. It might be to do calcium scoring, which can look at your risk going forward into the future. And more, there are more specialist things that we look at when we're looking at cardiology, because we know this is the most important area to zone in on as people get older, and making sure that people are managing their blood pressure and getting their blood pressure down to as low a level as possible. Rheumatology for people who maybe have rheumatoid arthritis, might have osteoporosis or osteopenia. They can be important areas to refer on to a rheumatologist. And it might be that the joint pain that people complain of, that we discover from our testing that they have some type of arthritis that needs to see a rheumatologist. And then lifestyle specialists such as nutritionists, might be someone to look at emotional health. They would be all areas that we very routinely get people to refer on to, and we can work as part of a multidisciplinary team with that. And that's an important part of, for me, of being part of the UPMC group, because we have all of these specialties at our fingertips somewhere. And a lot of the work can be done as part of a telemedicine consultation, or as part of, you know, a one referral on to someone and then back to us for their follow-up. So they're all important areas to be aware of. And I'm going to give you some resources to look at, because I think these are really, really important. So after the take-home messages from today is that menopause is very important. It's very important that we look after ourselves for the rest of our lives. We're going to spend a significant part of our working lives in our menopause. We're going to spend a significant part of all of our lives in our menopause. And the resources that the first one is the menopause.org, is the American Menopause Society. The next one is the International Menopause Society. And every time we do learning with either of these organizations, and they put up videos and webinars for us, they match it every single time with something for our patients and for lay people, so that we know that when we do some learning, our patients will have access to learning it in a more simplistic form for them as well. Then the DAISY network is an excellent UK resource for women who've premature ovarian insufficiency. And the Osteoporosis Foundation, another excellent resource, and it has calcium calculators and all kinds of information on preventing osteoporosis, exercise, nutrition, whatever. And then lastly, this is my new favorite resource, goredforwomen.org/menopause. This is everything you need to know about heart health, blood pressure, because this is the one we want everyone to be aware of, because the knock-on from all of the cardiac issues are the issues for your brain health, etc. So they're areas that you'll be able to, over days after listening to us, go in and research and see what you'd like to do. And as part of our network in Ireland, we have, as I said, a lot of hospitals, we have a lot of specialists, we have access to a huge amount of areas such as Santry Sports Clinic, rheumatologists, orthopedics, every area that helps us to look after the women who are coming to our clinics. So thank you for taking time to listen to us tonight.
Thank you, Mary. That was a really interesting talk. And we've got a number of things in, and we'll just, anybody, if you have any questions, please put it in the Q&A box, and Mary will be delighted to answer any questions you have. Just one of the first questions we have is, what about HRT and body-wide endometriosis?
That's an excellent question. So one of the issues with endometriosis, for people who may not be totally aware of it, is where the tissue that lines the womb is in some other places besides in the womb, and it bleeds every time it's stimulated by the hormones in the menstrual cycle in younger people. So often when people are older and they go on HRT, there's often the potential that endometriosis will be triggered to grow again. So we'd be very specific in how we'd manage someone with endometriosis in menopause. And really the first stage of it is to do a really good symptom history with them. And it might be that we can manage their symptoms without necessarily putting them on estrogen-based HRT, or we might put them on a very low dose one. And often it's very useful as well to link back with the consultant who looks after them for their endometriosis surgery. And I'm very conscious as well at the moment that a lot of people are going abroad for endometriosis surgery and endometriosis treatments. So it's really important that they have access to their surgical notes and their care plans so that we have those in the future when we're looking to care for them at the time of menopause. So there are lots of options. We can use HRT perhaps, or we can look at alternative options to HRT. And I suppose the other thing that is, since someone brought up the issue of endometriosis, to be aware that if someone has had multiple surgeries over the years for endometriosis, they might have had a lot of their ovarian tissue removed at various stages. So they're potentially at risk of perhaps entering the menopause at an earlier stage. So they should be aware of that. And it's something maybe patients with endometriosis don't get told. So very important for them to zone in on their care.
Great, very much, Mary. The next question it's probably was joint pain, and it's really, I'm suffering from terrible joint pain. I'm 56, been through menopause since I was 51. And I have no real problems, but I'm sure that joint pain is affecting their quality of life. And, you know, is it a common symptom, or what would your approach be?
Yeah, we a lot of women will complain of joint pain, and very often women will find some resolution to joint pain when they start on HRT. So, for example, there's different types of joint pain. I suppose that's the first thing to say. If someone comes in with a pain in their hip or a pain in their knee, and it's just one specific joint, that's more likely to be something more orthopedic or wear and tear. But when people come in and they complain of generalized pains in the small joints in their fingers, their toes, whatever, there's always the possibility that it could be something else. So we would, in that situation, probably screen for other rheumatological conditions like rheumatoid arthritis or inflammatory arthritis, and then refer on perhaps within our network of consultants to rheumatology or orthopedics, depending on what we think. So it might not always be relieved by HRT, but we would have the ability at least to investigate and see who's the right person to look after them.
Great. A number of questions coming in, which is great. And the next one is, what are your views on testosterone for menopausal women?
Okay, well, this is a very contentious question, as I presume a lot of people would be aware of. Women come in and they've heard so much about testosterone being good for energy levels. The evidence isn't very strong on that, but you know, you have to take each patient on their own individual circumstances. As testosterone is licensed really for libido and sex drive issues, but it does have a place sometimes for energy levels. And I suppose when someone comes into us and they're exhausted, and this has happened to me in a good few consults recently, where they come in and they think either more HRT will help them or adding in testosterone will help them. Sometimes you have to step back and maybe do questionnaires to look at burnout, look at thyroid problems, look at other issues. So it's about having a really holistic approach before you decide to dive in and say, yes, testosterone will make a difference. Where testosterone can make a difference is for women who've had their ovaries removed at the time of hysterectomy, because they lose their testosterone quite dramatically. So yes, it's something we prescribe. It's something I do prescribe prudently and cautiously after doing a really good assessment, though.
Next question is somebody who obviously regarding family history, medical history. Is HRT suitable if a family member suffers from cancer?
Well, first of all, it depends on the cancer that's involved. So, for example, we're giving people HRT. If we're giving them HRT, it contains estrogen and or another hormone called progestogen. And perhaps, as you've mentioned, testosterone came up as well. So there are a few tumors that can be hormone driven. I suppose breast cancer is the one that springs to mind. And cancer of the womb is one that springs to mind. But a lot of cancers and the majority of cancers aren't driven by estrogen. And even when someone has a family member with an estrogen driven cancer, we would still step back and get them to consult with, particularly in Ireland now, people who have a family member with breast cancer. Often the oncology and the breast cancer teams reach out to the rest of the families for screening. So people will be screened and will have the ability to make decisions. And I think the other thing to bear in mind as well is that just because someone has symptoms of breast cancer, of menopause, sorry, and they're worried about breast cancer, there are other drugs that can be used and other modalities that can be used for managing their symptoms without it necessarily being hormone based. So it's always worthwhile to have a consultation based around your menopause symptoms so we can look at what are the right options for you. And I've seen people with, I saw someone in the last couple of days who has a sister with breast cancer, two sisters with breast cancer actually. One is estrogen driven, the other is progesterone driven. And I'll get advice from her sister's consultants, and we will then sit down and see what's the best care for her.
Good. I suppose slightly related is how long can you stay on HRT? I'm 61 and I started HRT about 4 years ago.
4 years ago. Okay. Well, I always say it depends on the reason for going on it in the first place. And obviously, quality of life is important. Usually, when someone's been on it for 5 years, we might do a little step back and look at the dose, maybe look at whether a lower dose would help. And we know people worry about how long are you going to be on it before you are seriously or significantly at risk of breast cancer. We would always do a review at 5 years. Definitely do a review at 10 years, and it might be that we would switch to different medications for their symptoms. But at the end of the day, it's about risk balance, it's about quality of life and deciding, giving the person the information and letting them decide. Because it might be that they've osteoporosis and the benefits to their bones are greater, or cardiac issues as well, because we would be really strong on that now about not putting someone at risk. And when you stop HRT, specifically if it's for issues relating to your bones, you can get a bit of dramatic bone loss at the time that you lose it. So it's to prepare for that stopping. And it might be that we would link in and put them on something else for their bones or their heart in the interim period.
And is costochondritis connected to perimenopause, menopause?
Costochondritis for people who are listening, it's inflammation of the joints in your rib cage where your bone and cartilage meet. And it can be a symptom of menopause, but it can be lots of other things too. And sometimes people benefit and it is relieved by that. And we would always, again, as I said, link in with our specialists in the rheumatology field if it was a complicated case.
So it's a question for somebody, and would it be recommended to ask my GP before I get menopause symptoms about beginning HRT? As a full-time wheelchair user, my muscular dystrophy, might it help with bone health?
Well, someone who's wheelchair bound and with muscular dystrophy, obviously they have risks for bone thinning, they have risks for muscle wastage as well. HRT we're using really to manage symptoms of menopause, but for someone like that who's quite complex, they really would benefit, probably not taking it until they reach menopause, but I would see that person as being someone that would really benefit from even having a DEXA scan done to see what is their bone status now and what can be done for preventing bone loss. If they've bone loss already, do they need to be on something to build bone back up? So, and looking at an exercise program for them as well. So there's lots of benefits from someone with a wheelchair bound person to have an exploring of their issues. They would really benefit, I have to say, from seeing a lifestyle medicine consultant in conjunction. So lifestyle medicine would have huge benefits to them, looking at their diet, seeing what exercises can they do when they're wheelchair bound. Are they able to go, for example, and do aqua exercises in a pool that manages people with disability? So lots and lots of options to look at.
Thanks, Mary. Can female frontal alopecia be a symptom of estrogen depletion post-menopause?
Most alopecia is hair loss for anyone who's listening. So a lot of hair loss is often related to male hormones rather than female hormones. So it's the imbalance that happens at the menopause. But we also look at iron deficiency. Anemia can be, if someone is deficient in iron, that can be related to it. And thyroid issues can be related to hair loss as well. An awful lot of hair loss is actually related to stress and other underlying conditions. But I would say to anyone who has hair loss, the most important thing you can do is not let it get out of control, because often when you have scarring of hair follicles, it's quite hard to reverse out of that situation. So seeking help at an early stage is really important.
What is the risk in relation to testosterone use? Always there one. Yeah.
Well, I suppose no one should take a medication if there isn't a benefit to it. And every time we take a medication, we're trying to give it to someone at the lowest dose possible, and make sure that it's of benefit to them. Well, obviously, if someone's on testosterone and it's unmonitored, the benefits of, or the risks of excess testosterone is that people may develop excess body hair, they may develop hair loss in their head, they may get hoarseness or whatever from the changes of excess testosterone. So I'm not saying we'd never put people on it, we do put people on it, but we monitor their levels. And obviously someone who has excess testosterone levels potentially can affect their cardiac status as well. So it's just about being prudent and making sure that it's the only treatment for the symptoms they have.
Okay, a number of people are wondering how to get in touch with you for appointments. Do you do online consultations, or is it only in person?
We do online consultations and in person. There's always going to be situations where someone might need to be physically examined by somebody. In general, for menopause, we don't often have to do a physical examination, so we can do an online consultation. In an ideal scenario for someone like that, we might be able to get their bloods done locally wherever they are, either by the GP or within our network, and get their blood pressure checked and other things. But we should be able to, at the very least, start an online consultation and see what needs to follow on from that.
And I suppose this is you may or may not know the answer to this because it's more about a product being available, but what is happening to the Estradiol patch? It seems to be no longer available.
That's a supply issue. And it's a really difficult issue to overcome, because the supply, and it tends to go in and out of supply. Certain doses are out of supply, and then you run into problems with it. So say, for example, the 50 microgram patch would be the one we would have the most people on, and it goes out of supply. And unfortunately, what's happening is then people are being given generic patches that have come in from abroad. We're finding they don't stay on the skin as well, and they fall off. And undoubtedly, I think they're not absorbing the estrogen as well. So people get quite frustrated about it. So sometimes I would say maybe 225 microgram patches will work as effectively, and maybe we swap to something totally different. There's a transdermal spray and there's a transdermal gel. So if people can't get patches, they could swap to something like that. What I would say to people though, and this is a really important message, a patch or any drug that's made is made to be delivered in a certain way. So chopping up patches, we don't know if you chop say 100 microgram patch in half, what happens the delivery of the patch? Is it delivered as effectively? And the other half of the patch that's hanging around for the rest of the week, what's happening to that? So I think, if at all possible, that's not what people should be doing. They should sit down with their provider and with the person who's prescribing to see, is there an alternative that they could be using instead of chopping up patches.
Sorry for pulling you into supply chain questions, Mary.
It comes up at every meeting.
Be good. Can menopause trigger celiac disease symptoms?
Can it trigger
celiac disease symptoms?
Probably not, because if you're celiac, you've probably been celiac for a long time. But what I find is that maybe when menopause comes along, that symptoms that have never been that bothersome before suddenly become bothersome. One of the things that happens is that at the time of menopause, now I'm not sure obviously what symptoms they're having of celiac disease, or whether they've even had a diagnosis, but the effect of menopause on the smooth muscle in your gut can affect the way your gut works, and you can become more bloated because the smooth muscle isn't working as effectively, or you can become constipated. So it may be that coming to menopause has just brought a symptom to the fore that they never noticed before.
Would you encourage perimenopausal women who do not have hot flushes or other significant perimenopausal symptoms to take HRT for its proactive benefits?
Well, I suppose there's two aspects to that question. Is they're obviously having symptoms if they mention they're having hot flushes and sweats. And the issue for them is that are they bothersome enough to be doing something about it? It definitely is worth having an assessment and having a consultation to see what other health risks are there. For example, their bone risks, their brain risks, their cardiac risks. And sometimes, depending on how young the perimenopausal person is, because perimenopause can start as early as 38, that sometimes the oral contraceptive pill in lower doses will give them the same benefits as HRT or even better benefits. One of the things that happens in the perimenopause is that the hormonal variations are almost so erratic that they're changing from hour to hour, day to day. So people's estrogen levels are absolutely up and down like a yo-yo, and their symptoms can be a lot more dramatic. So sometimes the pill balances that out rather than HRT. So it's really about looking at each individual person and seeing what their needs are.
This one, I was diagnosed with osteoporosis at age 30. I've had, I'm sure this is physical therapy, but PTH therapy, physical therapy. And now at 52, I'm on biophosphonates. I'm conscious it's only 5 years. Where do I turn after 5 years? And I'll only be 54 when the 5 years is up. Currently on HRT for the last 14 months.
Okay, oh, that's a really complicated question. Well, the first thing, and I know it's probably been said earlier this evening, we reach our peak bone mass in our 30s, and bone mass diminishes after that. And someone to have osteoporosis in their 30s for whatever reason, that's really quite worrying and quite significant. And yes, they will benefit from being on HRT. That'll be a huge benefit to them. And bisphosphonates, maybe there are other drugs on the market that could be looked at as well as bisphosphonates for them. That's certainly someone that if they were a patient of mine, I would see a huge role for a rheumatologist in being involved in their care. And maybe there is a rheumatologist involved in their care, but they shouldn't worry, because at the end of the 5 years, there will be other drugs that they can go on besides bisphosphonates. There are so many other drugs that are superseding bisphosphonates that maybe it is an opportunity for them to explore seeing a rheumatologist.
Do I need a GP referral for consultation, or can I self-refer?
We take self-referrals. If we take self-referrals, though, it's nice to get a little summary of why the person is coming in advance so that we can actually make good use of the consultation at the time. I would say as well, though, that it's very important that we can communicate back with their GP, so the GP is in the loop with what's going on. That just becomes important because of other medications they might be on as well from their GP. So yes, we will take self-referrals, but we would be very keen to communicate back to the GP.
We will send out contact information how to contact Mary after the call. It'll be an email after the call. Carpal tunnel experience in pregnancy and now back in perimenopause, menopause. Is carpal tunnel common returning in perimenopause, menopause, or would HRT help this?
I can't say that I've ever yet in all my years had someone where carpal tunnel has come back, but carpal tunnel syndrome, or for someone who's listening who hasn't got it, it's where the tissue at your wrist presses on the nerves in your that are passing underneath the nerve supply to your fingers, and it can be really debilitating in terms of symptoms. So obviously there's some link there as to why it's come back at menopause, and it's obviously hormone related, and they should seek help on that because it's a really debilitating thing, and just being able to have a grip and have good muscle supply. So that's again either rheumatology or orthopedics in conjunction with us.
Would you encourage perimenopause women who do not have hot flushes or other significant perimenopause symptoms to take HRT for its proactive benefits to bones, brain, etc.? This question was asked, but she didn't seem to catch the question properly as she answered differently. Sorry. Yeah. So
okay, sorry, I didn't answer it right. Okay.
Yeah.
I think that going on a medication to potentially prevent something that might happen is probably not the right way to go about it. I think that for someone like that, having their consultation to look at the risk. So say, for example, they're obviously worried about some risk. So for example, they could go to a consultation with us or with a lifestyle medicine or whatever and do their cardiology risk score. They could look at their dementia risks. They could look at their osteoporosis risks. And then maybe there is another way of coming at their prevention of ongoing issues as opposed to just purely HRT. So for example, it might be really valuable for someone who's worried about cardiology to have a really intense cardiology assessment and look at what they can do lifestyle wise. And maybe HRT is part of the mix for that, but really HRT is for dealing with hot flushes and sweats as a primary thing. So maybe lifestyle medicine is their route as well. I'm sorry if I haven't answered it effectively.
Thanks, Mary. How does the Marina help menopause symptoms, or should you have it?
Okay. The Marine is a coil with hormone built into it called progestogen that we use primarily for contraception and for dealing with heavy periods. There undoubtedly are some women around the time of the menopause that do find it beneficial. It doesn't have estrogen in it, and we do use it as part of HRT for the progestogen side of HRT. So that's really, for that one person, they need to have a chat with their GP or whoever to work out where the Marina might benefit them.
Okay, that's very okay. And the final question is, how do you decide on dosage of HRT? Is it a response to symptoms?
Yeah, and depending on the age of the person, it'll be in response to symptoms. And sometimes, we'd start on a fairly average dose of, usually 50. Some women might like to start on a lot lower dose or the equivalent in their spray and titrate upwards. It depends on how we're always trying to have people on the lowest dose possible, but it's about working it up for them to get their symptom relief.
Look, thanks very much, Mary, and thanks to everyone who tuned in tonight. It's been really informative, Mary. There will be an email going out after the webinar with a link to watch the webinar again, but also with contact information for Mary. Is there anything you'd like to say, Mary, before we say goodnight to everybody?
Well, I'd like to thank UPMC for putting on the webinar. I'd also like to say that I'll be in UCD on Saturday at a longevity summit, which is going to deal with, I'm dealing with aspects of menopause, which is sleep and mood. And obviously it's going to link back into a lot of what we talked about tonight in midlife. So yeah, just thank you for organising this and to the team who put together all of the techie stuff in the background.
Thanks very much, Mary, and thanks to everyone who tuned in tonight.